Assalamu alaikum everybody, and welcome to today's session that's been organised by Muslim Doctors Cymru on men's health. The topics we'll be covering today will be prostate cancer, testicular cancer, and mental health. If anyone in the audience or on live stream have any questions, then please feel free to ask us. And especially for those who are on the live stream, please ask us in the comment section, and some of the team members will inform me, and I'll ensure that the panelists will answer those questions. I'd like to take this opportunity to thank Dawal Isra Masjid for allowing us to host the event in their mosque, and inshallah we'll have more of these events in the future. So firstly, I'll go ahead and ask the panelists to introduce themselves. So if we start to my right first.
My name is Dr. Jhanzeb Iftikhar. I am working as a specialty doctor in Oncology department, Singleton Hospital, Swansea.
Thank you. And to my left?
Sure. So my name is Adeel, Siddiqui. Working as a consultant psychiatrist in Swansea. I work for general adult psychiatry.
And to my far left?
I'm Amir Ghanghro. I'm GP in Cardiff.
Okay, so if as we're going along through the session, if you can't hear us or you find that the sound is an issue, please let us know, and also on the live stream as well, put it in the comment section so we know. So the first topic today that we're going to be talking about will be prostate cancer. So I'll start off with Dr. Iftikhar, who's an oncologist, to first tell us what is prostate cancer and what are the symptoms.
So prostate is basically a gland that is at the base of the bladder, and it surrounds the tube which takes our urine out of the body. So normally this gland grows with time. However, if it grows with uncontrolled manner, we call it prostate cancer. Prostate cancer is the most common cancer in men in UK, and about 1 in 8 men in UK have prostate cancer. This cancer is, however, common in population aged above 65 years. It does not mean that this cancer cannot occur in young people. It can occur in young people, but this is very uncommon below the age of 50 years. Speaking of the causes of the prostate cancer, to be honest, we doctors do not know the exact cause of the cancer. There are certain risk factors which put you at the risk of having prostate cancer. Having those risk factors, one or more of those risk factors, does not mean that you are going to have the prostate cancer. It only means that your risk of having prostate cancer is increased. The most important risk factor is the age, as I have already told that the increasing age is a major factor. Then the other risk factor is ethnicity. We black people are more prone to have prostate cancer, and in fact, there are more chances of having prostate cancer in younger age group in black people. What is the cause of it? We don't know. Probably the genetics. Speaking of the family history, there are certain inherited gene changes which put certain families at the risk of having prostate cancer. There is no specific prostate cancer gene, but however, there are some special sort of genes, some breast cancer related genes and some bowel cancer related genes which put you at the risk of having the prostate cancer. And the fourth important risk factor is our dietary habits and sedentary lifestyle with overweight people. Overweight people are more prone to have prostate cancer. So people having your dairy, large amount of dairy food products in your diet, and then having increased quantity of the protein diet, including red meat, lamb, this certainly increases the risk of the prostate cancer.
Thank you very much, Dr. Iftikhar. So I'll now move to Dr. Ghanghro. Can I get a screening test for prostate cancer or an examination for prostate cancer?
So, I mean, there's no national screening test for prostate cancer because there is a test available called prostatic specific enzyme. And then that test can be done through your GP. But because it's a poor screening test, because the result actually doesn't mean that you may have cancer, but also the result, if it's high, it actually can be normal as well. So there are a lot of conditions in which PSA or the prostate specific enzyme can go high in your body, which are not cancerous as well. So it is not advisable to get a test unless you have any symptoms. So if you have any symptoms, you should go to your GP, speak to your GP. Then you may have some examination as well, a rectal examination or examination of your back passage to feel the prostate, to see if the shape has changed or size has increased. In addition, you may be offered the prostate specific enzyme test as well, which may then, along with the examination, may suggest that whether you need further testing or not. So it is not recommended to have a test if you don't have symptoms. But after 40 years of age, you can actually, if you understand the pros and cons of the test, you can actually request the test through your GP.
Thank you. And just because you mentioned if a patient has symptoms, so Dr. Iftikhar, you went through sort of who's at risk of getting prostate cancer and what prostate cancer is. But if you could explain to the audience members what kind of symptoms of prostate cancer, what kind of symptoms they should look out for that would ask them to go to see a doctor for testing.
There are a range of symptoms which can be present in a patient with prostate cancer. They could be difficulty in passing the urine, difficulty in initiating the urine, then urgency in passing the urine, and it could be in some people even blood in the urine, and then increased frequency of urine at night, increased need to pass the urine at the night time in old age people.
And sorry, just to add on to that then, but if these people have these symptoms, does that mean they have cancer, or does that just mean that they should go to the doctor?
If somebody is having one of these symptoms, they should report. That person should report to their GP and discuss these symptoms with their doctor, because these symptoms can be present due to some non-cancerous growth of the prostate. We call it BPH, benign prostatic hypertrophy. This is a medical condition which is non-cancerous and is treatable by the surgery. So if any of these symptoms are present, you should discuss these, the patient should discuss these symptoms with the GP, and then the GP can put the patient on the right track.
Thank you. And Dr. Ghanghro, you mentioned about sort of the PSA test. So if I had the blood test and it was high, do I need more tests?
So we have got a guideline or a protocol that's been followed locally as well. So if you have a PSA test done, because as I mentioned earlier on, PSA can go high in other conditions as well. Like if somebody is having a urine infection, the PSA can go high. So we suggest that if you've got a high PSA, then that should be followed up with a rectal examination of your back passage. And then in a month, if the rectal examination doesn't show anything significant, then we would tend to repeat the test in about 4 weeks' time to see if that was just one-off high result which has come back to normal. And in 4 weeks, if the test remains high, then we would refer you to the urologist in the hospital, who would go through further testing, which may include a biopsy. And before biopsy, actually nowadays, MRI scanning is being done as well to see the structure of the prostate and see if there is any growth present. So once the MRI is done, then you will end up being offered, if there's any suspicious lesions or suspicious structures in the prostate, then you may be offered to get a biopsy done to confirm the diagnosis of it. But there are again pros and cons of every test you are going to do. So your doctor at that time, when they offer the test, will discuss with you what are the pros and cons of the test. So starting with PSA, then having a rectal examination of the back passage, maybe a referral to the urologist, then includes a biopsy and an MRI scan, and then a biopsy.
And Dr. Iftikhar, obviously, when people hear that they've got cancer, it can be quite worrying. Is there any treatment for prostate cancer?
So the most important thing to consider is that, like any other cancer, prostate cancer is non-infectious. You cannot transmit it to other people. There are a range of treatment options for the prostate cancer, which are determined by a number of factors, by disease-related factors, I mean cancer-related, and then the patient-related factors. By patient-related, I mean the age of the patient, the presence of other comorbidities, the health issues. And by disease-related parameters, I mean disease stage of the cancer, and then the grading of the cancer. And after considering these parameters, the doctor decides which treatment option would be better for the people. If the patient is having no symptoms, the cancer is not growing, and patient is 70 plus, and there are health issues, sometimes we just consider watchful waiting. Watchful waiting is meant wait and watch. Wait and watch until the cancer grows or the symptoms appear. And when the cancer grows or symptoms appear, then we can add on some special hormonal therapies. The prostate gland needs testosterone hormones, the male sex hormone, for its growth. There are some special hormonal therapies which can suppress the production of this, the action of the testosterone on the prostate. So by these hormonal therapies can be very beneficial. And in some cancers in which then, as I said earlier, it depends upon the stage of the cancer. It could be in the surgery, and then there are various types of the surgery. It could be radiotherapy.
Yep. And any side effects of the surgery?
Yes. Speaking of the surgery, the major concerning side effect with the surgery is the erectile dysfunction, which can happen in patients with prostate cancer because of during the surgery, the nerves and the blood tissue and the blood vessels which are involved in the process of erection can be damaged. The surgeon can try for the nerve sparing surgery, but it all depends upon the actual involvement of the cancer. When the patient opens up the body and sees that the nerves are involved, the surgeon has to remove the whole bulb. And if the erectile dysfunction has occurred after surgery, it is not likely going to recover. Then the other major side effect is what we call it's called dry ejaculation. Dry ejaculation is the term. The patient having the prostate surgery can still have the orgasm, but there will be no ejaculation. And if there is no ejaculation, it means that patient would become infertile permanently. This has to be told to the patient categorically and in clear description, because the patients who are going for the prostate surgery should be offered sperm banking if they are planning their family in long term. And other complications of like damage to the bladder can lead to urine incontinence in some patients. However, this can recover, and the recovery time can vary from weeks to months, and it varies from person to person. And the last major side effect, long-term sequelae, can be a stricture of the long tube carrying the urine out of the body. And if there is some stricture, the surgeon can do some mild procedure to dilate that stricture to remove.
So just for our audience members, regarding a stricture is sort of narrowing of the urine tube. And obviously you mentioned radiotherapy. We use radiotherapies in quite a lot of cancers. Are there any side effects to radiotherapy the patients may want to be aware of?
Yes, radiotherapy can also cause erectile dysfunction and infertility, but that is not that much well determined with the radiotherapy. The major side effects associated with the radiotherapy can be tiredness, the fatigue, which can be helped by increased physical activity. And then effects on the skin, where you receive the radiotherapy. There could be darkening of the skin in dark people and redness of the skin in the fair-skinned people. There could be loss of the pubic hair in that area, which can recover after some time. Then there could be Other changes, because when you receive the radiotherapy, there can be damage to the surrounding organs. It could be damage to the surrounding bowel and the back passages, which can lead to diarrhea in some patients and crampy abdominal pain. If that is the case, your doctor would advise you to increase your fluid level to 2 to 3 liters per day and avoid alcohol and caffeine. One important thing for patients with the prostate cancer who are going to have surgery or radiotherapy are advised to quit smoking if they are smoking, because the effects of radiotherapy are more pronounced and well if the patient quits smoking. And that also you can be prevented by the chances of having chest infection post-surgery. And then speaking of the bladder side effects, it can lead to bladder incontinence, or inflammation of the urinary bladder, which can present as burning feeling while passing the urine, or it can be inflammation.
Okay, we've had one question online, and it's from a trainee doctor. I guess it's important because with COVID and the pressures we've got on the services, it's important that we do get these patients referred quickly and appropriately. So as a trainee doctor, junior doctor, as a GP, what kind of things would you like us in the referral letters to ensure that that you get all the important information quickly, so that the patients are seen as soon as possible?
It would depend upon the patient scenario. I mean, if the obstruction is not very, I mean, if the symptoms are not very gross, I mean, it would depend a lot upon the whole clinical picture. If we are expecting that the disease is locally advanced, by locally advanced, I mean that if the prostate gland has two lobes and it has an outside capsule, if the disease remains outside till the outside cover, we call it locally advanced. But once it spreads beyond, then it becomes stage 4, and we call it metastatic. And in that patients, in those patients, the intent of the treatment is just to control the disease, not the cure. So if we are expecting that patient is having too much, a lot of symptoms from significant amount of time, and in the imaging shows that the disease is locally advanced, then those patients fall in the category who need to be referred to the team urgently, so that they can be prevented from being stage 4 or metastatic setting.
Kasim, I would just like to add a bit on referral. You mentioned, obviously, Wales got different referrals to England. England has got a 2-week referral, but Welsh government has got different pathways of cancer referrals. Any cancer referral has to be urgently suspected cancer marked on the referral. So it is important to provide that information when you're doing a WCCG referral. The referrals of suspected prostate cancer go to urologists. So it's important the referring doctor should select the urgent cancer suspected. A rectal examination or examination of back passage should be included in it, any findings from it. And as I mentioned earlier on, a prostate specific enzyme should be done at the beginning. And if it was just one-off, it should be repeated. So 2 prostate enzymes which are high plus a rectal examination would definitely fit the criteria of urgent suspected cancers, and include all the symptoms the patient's having as well. Especially the family history is also important, as Jhanzeb mentioned earlier, that if somebody in your family has got prostate cancer, then obviously the risk increases. I think we've got a question from the audience.
Yes.
Yeah, I just want to have some clarification. I've got a relative who's 85 years old, and he's got some vague symptoms, not some significant symptoms, just some vague symptoms of his urine. He's got other comorbidities, he's got other illnesses, he's got heart disease, he's got diabetes, and he's very frail. And I think in terms of getting the PSA test, he doesn't really want to go through all that process and end up with nothing can be done. Would you advise he has a PSA test? Because he can live with the symptoms, he's got other illnesses, and he doesn't really want to go through the process and come at the other end with nothing that can be done. Just want to know what you think.
Okay, just because for the live stream as well, so they hear your questions. So we've had a question from the audience member. They've got an 85-year-old relative who's got very vague urinary symptoms and has obviously got other medical problems, quite frail. And should that person have a PSA testing, or should they go ahead and have all these, from what I presume, sort of invasive tests, or should they be left as they are? Is that your question? So that's the question, and obviously that is quite a common scenario faced by GPs on a regular basis. When is it necessary to act, or when is it that we just let things be? So Dr. Iftikhar, can you answer that question?
Thank you very much. It's a very good question. As I told earlier, that while we are speaking and discussing the treatment options, the first option is the watchful waiting, and in patients with age greater than 70 and having comorbs, as you were telling. So if those patients are not having any symptoms and we are not expecting the cancer to grow, you can consider watchful waiting. I mean, wait and watch till the cancer grows or the symptoms worsen. But as you told earlier, that you are expecting that the symptoms are there. So in that case, if he's having health issues and is having age of 85, now we would assess the quality of life in that patient, and most probably, if it turns out to be the prostate cancer, in that case, our intention would be to just give hormonal therapy. And that hormonal therapy, there are a couple of options. In some patients, we just give monthly intramuscular injections, and even in some patients, we give implant under the skin of the tummy, and it stays there, and it's effective for 3 months' time. So having these hormonal therapies can certainly improve the quality of life of that patient and can improve the symptoms of that patient. It would certainly depend upon the benefit versus harm. The hormonal therapies, to be honest, we don't expect them to cause much harm. They can, the major harms associated with them could be hot flushes, night sweats, mood changes, but not in everybody. I'm just telling you about the possible side effects. So if he's having symptoms, the first thing, he should be evaluated by a proper GP, and the GP then should decide whether he needs to be referred to the urologist or not. And I would say that he should at least get himself evaluated. It could be, as we discussed earlier, not every patient with these symptoms is having prostate cancer. It is a possibility that he could be having something else. So instead of making his own diagnosis, I would suggest that he should seek opinion of the GP for this, so that the GP can then decide upon whether the need of the referral for a urologist is needed or not.
Should he have a PSA, or should he just wait till the symptoms get worse?
So the question was, should he have a PSA or wait until the symptoms get worse? And we're talking about an 85-year-old who's old, frail, with multiple medical problems.
I'll answer that question. Thanks. The question about PSA is, as we mentioned earlier on, there are pros and cons of the test, whether you can miss the cancer when the test comes back positive, and even when it's negative, you can still have the cancer. When somebody's got symptoms, we need to understand that about 80% of the men who are above 80-year-old will have some sort of prostate cancer going on. And as Jhanzeb mentioned, that not every sort of prostate cancer needs treatment. I think if somebody has got symptoms, it's important to have an examination, which is minimal invasive, which your doctor does it in a private room, and it will guide us what to do next. PSA again is an examination, which is a test which is minimum invasive with the blood taken out. And when the PSA result is back and the examination finding of your doctor, we can put things together and then make a clinical diagnosis whether that person has got more risk of having a cancer or not. Again, as I mentioned earlier on, previously we didn't do any scanning or imaging before. Now there's a MRI scan being done. So again, MRI scan is a non-invasive sort of a investigation which can lead us to more diagnostic criteria being sorted. So I think it is important that not to ignore the symptoms, because at early stage prostate cancer can be treated very well and needs to be monitored as well. If you leave it too long, then as Jhanzeb mentioned, it can spread through body into your bone, liver, other parts of body, and then obviously it will affect the quality of life as well. It will be difficult to treat. So early symptoms should not be ignored. Speak to your GP, and if there is a need of PSA or any other test, that should be done.
Before we move on to our next topic, do we have any other questions, either in the comment section or in the audience? Yes?
Could the PSA test be done at home?
So the question was, could the PSA test be done at home?
No. PSA is a blood test that needs to be taken to the lab. There's not a like a home kit that you can do. It has to be a test that is done through the blood, taken from by a phlebotomist or your doctor in the surgery, and then sent to the lab, and the results come back in a couple of days' time.
We have another question, yes?
Yes, it's about what you have said, brother. It's the high risk among the African or whatever you said. Even you said a jungle. As far as I know, and when I was about to do the test for my bowel, a family doctor told me that, from my family, told me that, look, I will give you a good news. You have a low risk. He made me very happy, of course. You have a low risk of having the cancer, the bowel cancer, or whatever you call it, for many reasons. MashaAllah. First of all, you are not a smoker, you are not a drinker, you are not to do these things. And so, inshallah, the risk will be very low. And alhamdulillah, mine is clear. Coming back to, I came from a village. I can't remember any member of that village who died of
prostate cancer.
Yeah. So where is the problem here, as you said? The other question, is there any relation between, if the person is young, is there any relation, if he got the cancer, will that affect his machine as a man?
Okay, so two questions. So if we take the first question first, is that obviously we mentioned that one of the risk factors with relation to prostate cancer is being of an African Caribbean or ethnicity, and that the gentleman is from that ethnicity, and people back home in your village, no one's had this form of cancer, and when you were seen by a family doctor there, you were told that you were low risk. So is it actually a problem for someone in his community?
So in terms of your first question, I would like to say that you were telling that you told that your doctor told you that you are having low risk of bowel cancer due to your ethnicity, isn't it?
Is it bowel or prostate?
Because
Because there's two different cancers.
So
Yeah,
that's
so
what I was
the
going to
normal
say.
test.
I'm just going to explain you the next topic of discussion is today is testicular cancer. The prostate gland and the testes are very nearby in our body. So the testicular cancer is more common in white people. So different cancer types have different predispositions. As I said earlier, having these risk factor does not, having the one or more of these risk factor does not mean that you are going to have prostate cancer, it certainly puts you at higher risk of having prostate cancer. It does not mean that you are going to have prostate cancer. It just puts you at higher risk. And you said that you never found anybody who died of prostate cancer. The fact is that this cancer is mostly common in people aged above 70 and 80. And in this age group, we certainly found a high number of people who died due to low respiratory tract infection or urinary tract infection. So sometimes these cases remain undiagnosed, and those people died due to the complications of prostate cancer. Let it be urinary tract infection or could be anything. And as the brother has already told that there is a relative of him who is 85 and he is reluctant to seek opinion of the doctor because some people feel embarrassed to discuss these symptoms with the general public. The next topic is testicular cancer, and I tell you, this is one of the most well treatable cancers in our whole body. But the main issue is that we have seen multiple people, even young people, who tend to avoid presenting these symptoms because of social dilemmas and embarrassment. If there is swelling in their scrotal area, testicle, they would generally tend to avoid to present these symptoms to the doctor and hide it from their family. So what it leads to an advanced stage, and many people die of it even presenting with that cancer. So that's why this webinar is all about we need to highlight this social stigma of not presenting with these symptoms.
And the second question was that obviously you mentioned surgery, radiotherapy could cause erectile dysfunction, but if you had prostate cancer, would that affect would that cause erectile dysfunction or have any effect?
Okay. So prostate gland has two parts. It has a glandular component and it has a muscular component. The glandular component basically produces fluid, and the erectile dysfunction or the reproductive capacity depends upon the semen. The male semen is composed of two components: sperm coming from the testes and the fluid coming from the prostate. The fluid of the prostate makes the sperms, gives the sperm the mobility and the fluid so that it can go and fertilize the egg to make a baby. So if the prostate cancer has not affected the glandular component and the prostate cancer is still producing the fluid, that fluid can just mix with the sperm, and the patient can have the reproductive capacity. And the erectile dysfunction, just like the surgery, if the cancer has not advanced and not involved the nerves and the blood vessels involved in the process of erection, then erection would not be affected. But if the cancer has advanced and it has involved the nerves and the blood vessels involved in the process of erection, then certainly the erectile dysfunction would be disturbed. Yes.
In ejaculation,
Yeah.
sometimes there's what causes a reduced amount? It's only a very small amount. And then other times it's more.
I'll answer. So the question was that in ejaculation, what can cause a reduced amount or no amount sometimes?
I mean, this is something not related to.
No, it's not related to the
So
prostate cancer.
Yeah, I can answer that question.
But yeah,
It varies from person.
yeah, because
It is
there's
something-
lots of reasons other than to do with
The
prostate
amount
cancer.
of ejaculation. No, so as Jhanzeb mentioned, that the liquid that comes out with your sperms is coming from the prostate gland as well. So actually, to have the healthy sperm, the prostate fluid is important. The amount of fluid, how much it comes out, or it depends from person to person and your body and the hormonal effects as well. Body goes through a lot of changes throughout the day. The hormones go up and down. Obviously, somebody having frequent sex may have small amount of ejaculate coming out. or if you've had sex after longer time, then you may have more amount of, so it doesn't really matter. And the amount does not affect the ejaculation or the fertility.
So we're halfway through, we've still got 2 topics. So we're going to now go on towards testicular cancer. So my first question to Dr. Jhanzeb is, who gets testicular cancer? We talked about prostate cancer, but sort of who are the type of people who get testicular cancer?
Testicular cancer is although a rare cancer, but it is relatively common in people of younger to middle age group, up to 50 years of age. So the people who tend to have, as with the prostate cancer, there are no, we don't know the cause of the testicular cancer, but there are certain risk factors which put you at higher risk of having testicular cancer. The first, the major risk factor is the undescended testes. In an unborn baby, the testes develop in the tummy, and then they grow down and they migrate down to the scrotum by the birth or by age of 1 year. If they do not go down and they remain in the tummy, these testes can be the risk of testicular cancer. Then in some patients, there are some abnormal cells. We call it carcinoma in situ in our medical term. These are abnormal precancerous cells in the testes. We come to know about it while we are having a testicular biopsy for infertility or some likewise issue. These patients can have testicular cancer in long term. In ethnicity, white people are more prone to have testicular cancer. Then family history, then have HIV. HIV has human immunodeficiency virus causing AIDS, has association with certain types of the testicular cancer.
Okay, and what are the symptoms for our community to look out for when it comes to testicular cancer?
The first and the foremost important symptom is the abnormal swelling of the testes. It could be painless abnormal swelling, and then it could be pain or discomfort there, or it could be size of one testis being larger than the other testes.
Okay, thank you. Amir, Dr. Ghanghro, sorry. Is there any tests available to detect testicular cancer?
So there's no particular test or screening test for testicular cancer. It is a self-examination. So we advise all men to examine their testes regularly to see any abnormal lumps or swellings are appearing. So obviously, if one testis is bigger than other or any abnormal swelling has come, you should contact your doctor, get yourself checked out. So once if we find a lump, then we can actually send you for a test called an ultrasound, which would detect more of the structure of the that lump or swelling and would guide us what to do. Well, if we suspect any swelling, then first we do an examination. Doctor is going to examine you in a private room with your consent, and he might shine a torch against your testis or the scrotum, or to see if the lump is very solid and does it let the light pass through it. Because some of the swellings of the testis could be benign or non-cancerous, and they can be just a fluid filled around the testis. That's what we are checking when we are shining the torch. If that light is not letting it pass through, that may make us suspect that it is a solid structure which might need an ultrasound or a further test to determine the exact structure. And if that comes back suspicious, then we may refer you to a urologist again, who would again further do some more tests. A biopsy might be done as well, and some hormone test can be done as well, which would let us know what type of testicular cancer it is. Jhanzeb just mentioned that it is one of the rare sort of cancer. We don't see it very regularly like prostate cancer, but it is one of the cancers that can be easily treated. So it should not be ignored. Any swelling of your testis should not be ignored, and you should get examination so that treatments can be given in time.
So we'll move on to the last question and on this, but then as Dr. Amir has said, there are treatments available. What are those treatments?
So in terms of the treatment options, the first and the foremost treatment is to, if the staging, the investigations show that the disease is localized, then the first and foremost treatment is the surgical removal of the testes. Surgical removal is important in this term that if we just go for the biopsy, then there are chances that there can be seeding of the cancer to the other testes. And then after surgery, it would depend upon the pathology report of the surgery, whether we need to have additional treatment or we can just observe the patient. In some patients who have a complete surgery, we don't need to have, if the patient has presented at a very early stage, then there are chances that he would just need to have surgery and nothing else. And not even chemotherapy. But in some patients, we have to give chemotherapy depending upon the stage of the disease. It could be 1 cycle or 3 cycles.
We have a question.
I think you touched on this, but just wanted a bit more clarification. Apart from having a lump in the test in the scrotum, what are the symptoms that we can expect from a person with testicular cancer, apart from the lump?
It could be pain or discomfort in that area. These are the major symptoms of that can happen: pain, discomfort, swelling, discordant size of the testes on both sides.
Would they have a problem with ejaculation? Would they have a problem with the content of the ejaculate? Could they have a problem with that?
No. Even after surgical removal of one of the testes, the other testes can do the all work, and the patient can have the whole reproductive life normally. Even after removal of one testis. But in those patients, we generally tend to advise them to avoid planning the family for 6 months to 1 year. 6 months for patients having radiotherapy, is 1 year for patients having chemotherapy, because both chemotherapy and radiotherapy can certainly affect the sperm morphology and structure.
Okay, so we're going to move on to mental health now. We have with us Dr. Siddiqui, who's a consultant psychiatrist. Thank you, Dr. Jhanzeb, for all the cancer questions that were done and for extremely useful. We're moving on to mental health. As many people know, this can be a very taboo subject in our communities, and so it's equally as important as cancer in our communities. So my first question to Dr. Adeel would be, what are the common mental health problems we see in men?
Right. Thank you very much. So there are no specific mental health problems for men. So that's the first thing that we need to understand, that any mental health problems that could be seen in general public, so that applies equally to men. So the more common ones would be anxiety and depression. And quite often when you see these patients, so they sort of present with symptoms that even somebody with anxiety would have some symptoms of sadness or depression, or the other way around as well.
And who can develop mental health problems?
Yeah, that's a very good question. So, so again, anybody could develop mental health problems. So this feeling that if a person is strong mentally, would never develop mental health problems. So that's a wrong concept. So anybody could develop mental health problems because a lot of the mental health problems could be considered as biological. There's something changing biologically inside the body or the brain that leads to the symptoms of mental health. Obviously, there could be psychological or social factors as well. But the common message that I want to give is that, well, anybody could develop it anytime in their life.
Okay, thank you, Dr. Adeel. What are the sort of common symptoms of depression that we might see in patients?
So depression is one of the more common mental health problems that could be seen in general public and in men. The symptoms generally we divide in two main groups, like biological, which is physical, and psychological, the mental health symptoms. So sometimes we think that because depression is a mental health symptom, so there'll be no physical symptoms, but that is not true. In fact, in Asian population or non-white population, the first symptom to present with could be physical symptom. So the biological symptoms would be decrease in appetite, poor concentration, there could be weight loss, there could be sleep disturbance, which quite often is the first sign of some of the mental illnesses. So change in the sleep pattern or insomnia, or sometimes even excessive sleeping could be an issue. Similarly, I said low appetite, but sometimes there could be increase in appetite as well. So these are generally the physical symptoms. The other ones would be lack of libido, so reduce in interest in sexual life as well. And in psychological symptoms, then there is, as you can expect in depression, negative thinking about yourself and people around you or your future, feeling hopeless or helpless, or feeling worthless, or having sort of negative thoughts like thoughts of harming yourself. So these would be the psychological ones.
So I've had a question from Pakistan, actually. Okay. So I know the person. So the question was, how can we help if anyone is facing mental health issues around us? Because mostly people avoid, I think, the person in question.
Right. Okay. So this is not only possible in Pakistan, even in UK. It is quite commonly seen that mental health problems are seen as a weakness. Sometimes some people think it's shameful to talk about mental health problems. There's a general feeling that if I talk about my depression, for example, everybody will think that I'm a weak person. But again, as I said, this is purely biological illness. If we compare it with any other physical health problems, it's not in our control. We don't decide that we're going to become mentally unwell.
So avoiding the person is not the best thing to do.
Absolutely. So it is, the most important thing is talk to that person, because talking is the first thing, because you need to start to give support and try to understand what is going through that person's mind, so that you can advise and guide that person to get the right help. Even if you're not a doctor, if you're a family member, or even a friend, or if you know somebody, you know, and you see some changes in their general interaction or behavior, if you think somebody is sort of losing weight, or if you see somebody more emotional, more than normal, then I think talk, because talking is the first point of contact, really, first thing that you should do.
And not to isolate them.
Yeah.
Yep, so we have a question from the audience.
Can I ask, is it common to get a diagnosis of depression and anxiety together? And to take it back to the first, can anything to do with the male function, you know, the prostate, whatever, affect the depression or anxiety?
Excellent question. So the first question is, can you have anxiety with depression, or do you just have depression?
Sure. So both are possible. So you can have pure depression with hardly no anxiety symptoms, but you can also have some symptoms of anxiety along with a clinical diagnosis of depression. So I mean, I think when we see in secondary care, what we try to decide which started first and which is the predominant symptom. If it is purely mainly depressive symptoms with some symptoms of anxiety, then the diagnosis would be depression. Now, your second question, whether prostate or testicular cancers could lead to symptoms of depression. So what we need to understand, that could be a secondary psychological effect. So anybody who suffers from a cancer or a serious physical health problem are more likely to have symptoms of depression or anxiety. So it could be just a response to having a major illness.
I think the brother wanted to ask.
Not the other way around.
Yeah.
One of the side effects, the first thing you get to know is when you're depressed or when you have anxiety, that you have that first before you know that.
Yeah. So the brother wanted to ask, the question is actually, does the lack of libido you mentioned, the sexual desire you mentioned, it's about that, can depression cause those sort of symptoms?
Was that the question? Yeah.
So I think,
So what exactly is the question about?
The question is whether depression can cause effect on sexual health.
so yes, I mean, yeah, I did mention. So, this is lack of libido could be related to mental health, especially depression. So it is one of those symptoms that could be, you know, I mean, especially people who don't want to talk about their mental health or do not recognize that they're suffering from depression, and they sometimes go to GPs with some physical symptoms, especially or possibly lack of libido, and it turns out that they have some underlying physical health problem as well.
Yeah. So libido is actually the sexual
It's a
desire, basically. So libido is a term used for sexual desire of a person. So if somebody's got depression, yes, certainly it can affect their sexual health. The interest in the sexual activity would be reduced as well. So they can present to their doctor with those sort of symptoms, not knowing this is due to depression.
Yeah.
I mean, but I would like to add that it should be the doctor who should be deciding whether who is causing these symptoms. Even there is some problem in sexual desire or something like that. It should not be the patient who should be thinking that it is just because of the depression. The patient should have a proper evaluation by proper GP and or the doctor, and then the doctor should be able to decide whether these symptoms should be put forward in the category of the depression, or it could be some organic proper disease related from.
I'm not a counselor. Huh? I'm not a counselor.
So I can try. Yeah, I can try. So basically, what Dr. Iftikhar is trying to say, imagine if somebody has prostate-related problem and that is affecting the sexual life of that person. That does not mean that we should just assume that this is purely prostate-related, because it is also possible that that person may also have depression, either secondary to prostate, having a physical illness, or a purely separate mental health problem. So I think we should not make a judgment, oh, it's all due to prostate and there's no point speaking to a specialist. Speak to your GP first, and they can decide whether they need an opinion from psychiatrist or a counselor as well.
And there's nothing stopping you having both.
Exactly.
A biological
Exactly.
issue,
Yes, exactly.
or a psychological
That's
issue,
what you wanted to say.
or it could be that one is leading to the other, and that going to GP, when Dr. Iftikhar is saying to decide, is to make sure that all bases are covered, whether it's biologically or a physical cause and or a psychological cause. So we have another question.
Yeah, thank you very much. I think it's, you're right, it's very important to get a mental health diagnosis as soon as possible. But I just want to have a chat about another relative of mine who's had a couple of bad weeks at work in their social life. And they went to the GP, and GP asked them the screening questions that they always do. And they were labeled with a diagnosis of depression. And they were put on antidepressants, sent to the counsellor, and that label has stayed with them for a number of months. Is there any danger of overdiagnosing mental health issues?
So the question is, you know, somebody going to the GP surgery and had a few weeks history of feeling low mood and was diagnosed as depression, put on antidepressants, and now that person has the label of depression, which will be on their medical files for the rest of their life.
And on their conscious.
And on their mind.
Okay, so I think the person that you're referring to, I think it is it was a good step that if somebody was feeling mentally not well, that they went to the GP. And we believe that all the GPs are capable of diagnosing depression. So it's not just relying on a questionnaire. It is a clinical assessment that a GP does. And they may come to a judgment. This is a clinical depression. It is not just somebody scoring high on a questionnaire that gives a diagnosis of depression. Because depression is considered as a mental illness which needs to be treated. So I'm confident that if a GP has made a diagnosis after a clinical assessment, the diagnosis would be correct. And if the GP decided that medication is the right way forward, because having depression does not mean that you have to immediately start medication. Sometimes psychological therapies like cognitive behavioral therapy could play a role as well. But if GP had decided to prescribe medication, then medicines should be taken for a period of 6 months, because a lot of researchers have shown that prevent the relapse of the depression. In terms of label, I think this is where I would say we should not worry too much about the labels. If somebody has an illness, then it's an illness, because sometimes this becomes a problem within mental health, that patients are reluctant even to come to us because they fear that they're going to get a label which is going to be a lifelong label. Depression is something, it comes and it goes. It could be that you had a depression, somebody had a depression and it was treated successfully and it never returns. And even if it returns, then you can successfully treat it again.
So can I just add something onto
sure.
that? So as Dr. Adeel mentioned, that depression is a sort of reversible, isn't it?
Absolutely.
So it should not be taken as a chronic disease that would stick to you for all your life. An important thing is to getting the right help is at right time. So if you leave it too long, it becomes a chronic disease then.
Absolutely.
If you get it treated early, especially the mental health problems, get the right help, right time. I think that's the most important thing, and the better outcomes can be expected as well. Often the medication is the given, but medication is the last resort rather than the first line of treatment. So we will talk about it in a few minutes about the medication as well.
Just want to just clarify, is it a danger of overdiagnosis?
Well, I mean, obviously, if it is incorrectly diagnosed, then that's a danger. With GPs are fully trained to make a correct diagnosis. It is, I mean, so I don't think that it is going to be overdiagnosed. One of the problems that sometimes is seen, because the psychological therapies cannot be provided as early in the diagnosis, so patients end up going on medication. So that may be one of the issue that one can sort of say, that actually medicines are easily available to GPs. This is within their power, so they can give a script for antidepressant, whereas the patient may actually only want psychological therapies like counseling.
So sometimes overdiagnosis is better to avoid getting these things underdiagnosed and not seen at all. But overprescribing is something that needs to be looked at, because often GPs, when you go to a GP is quite busy, has got less time, and that can be a constraint on general practice or your doctor as well, to give you a prescription, that an expectation of the patient that I want to get this fixed very quickly. And depression is not a disease that can be fixed very quickly, because it takes time to develop depression. It takes time to treat depression as well. So I think expectation of the patient and the doctor has to be more realistic here. And as over prescribing of antidepressants can be an issue, but I don't think over diagnosis of mental health problems should be an issue, because the more we diagnose, the more prevention of serious outcomes or bad outcomes from the mental health can be prevented.
So before we take questions, I just want to ask them, so how can we prevent mental health before we go on to talk about treatments and stuff? Is there some way what we can do to prevent it?
Absolutely. So, in terms of prevention, what we need to understand, that if we have a genetically higher risk, if there's a family history of depression, then we are at a higher risk of having depression. However, lifestyle is extremely important. Equally important for physical health as well as mental health. So, and by lifestyle, what it means, very simple things that we all should be doing. It's very much like having a good sleeping pattern, fixed time to go to bed, fixed time to get up in the morning, doing daily exercise, eating healthy diet. Obviously, other physical risk factors to generally keep your physical health, stable. is going to naturally help your mental health as well.
I believe we have a question.
Yeah. It's a very sophisticated matter. It's about mental health. Back home, as you know, in all, or most of the Muslim countries, we call the person who is mentally not very well, we call him Majnoon. Majnoon is, of course, came from the word jinn.
Yeah.
So they believe that there is jinn here
They feel that possession.
and there is a traditional whatever we call it, a therapy, or so they take I don't know about Pakistan or other countries, but in Sudan they take the person to what we call him a faqih. Faqih is from the word faqih, is like a pious person, and with that sheikh, he will have a hell of life. He will be hit to take this genie outside of him, and some, not some, most of them, they are chained, not to run away or to harm themselves. So the question here is your group, which is I have seen it as a fantastic group. Will you or I or you be talking to the community, the local community here? Because the majority among us are from from the old generation and still having this source.
So if shall I take this question then? So what you're mentioning is that culturally, shall we say, depending on sort of your country, if someone has mental health issues, they will say that it could be jinn or spirit possession.
And the word itself.
Yes, and that they will take them to some person who is of religious mind, imam, sheikh, fakir, and obviously what they may do, and what kind of things are we doing to sort of address that? Or
I guess yes. If we go to the community and talk about this matter, it might definitely that will help to improve it and to do something back home, because I can pick the phone when I visit and say, oh, that's wrong, you shouldn't have to do that.
Yeah, so this is the first step. This is the reason why we wanted to do these sessions, and inshallah in the future we'll be doing more with larger audiences for people to understand mental health. We're not here to sort of put any fatwas or religious edicts on anybody.
No,
100%. From what I would say as a doctor myself is that whoever you're asking advice from, whoever, needs to understand the topic as well. And that's where our role is, to work with imams and religious figures so they also understand mental health, and so that we work together, not against each other. So religion and science works together. So that is our hope. We're not there yet by any stretch of the imagination, but that is the aim of what we want to do in the future, is to have that. So yes, we will be taking that on board and going to the religious scholars, who they are many who do understand these things. I'm not saying that all of, there are many who are very knowledgeable in this topic and are very supportive in this topic. And it is important that the message we get out to everybody, it will then translate back in our home countries. Like I say, we're on live stream now and we have questions coming from Pakistan.
Yeah.
So it is something that we can do international to help, because you are right, there are some places where it's very questionable what is going on. Do you have another question? Sorry, I did cut you. I do apologize.
There is another matter. We can work on it together, inshallah, in the future. that what we call is ZAR. ZAR. I don't know the English term to that, but it's a mental issue again among women. They do specific things like dancing and they always dress in red. And inshallah, in your website, I can send you the exact these ceremonies, and we can in the future work on that as well. Because
Mashallah, we have lots of female doctors, psychiatry doctors as well. And so if there is a thing that we do need to bring to our female sisters in our community, we will definitely work with you in the future on that as well. No problem.
The other thing, as a social worker, I used to have some young Muslims, they are just complaining that there is whispering always, telling them things, don't do this, don't do that. So I gave them, what I can do, but is listen to them and tell them that there is nothing like that. This is just imagination. Try to, avoid that by making yourself busy and do so and so and so. So what is your advice for?
Yeah, so it's a very sensitive area, sensitive topic, and it's very important that you raise it. Thank you very much. So there are a few things that I would like to just explain to you. So we as doctors, we don't see that we are in competition with or competing with religious scholars of any faith. So we all have our own knowledge. So we have limited medical knowledge, and then obviously faith, religious scholars, they have their own knowledge. We all need to work together because nobody is denying that talking to someone, or even as I said initially, if you're struggling with a problem, talk. Go and talk to your neighbors or your friends or family members, or even to imams or any other religious scholar, because talking at least starts to release that inhibition. It gives you the ability to start to at least ventilate your feelings, and somebody is listening and give you advice. So as Dr. Kasim said, I think this through this platform, we should start to sort of work jointly and sort of clarify if there's any misunderstandings, misconceptions as well. The other example, you said that in your country, people are called Majnoon, isn't it? When they have, and you'll be surprised that actually even here in UK as well. So when I see patients with non-white background who have moved here, or even who were born here, they still have that cultural influence and their own, cultural or sort of religious beliefs that come into play as well. The way we try to deal with it is that go to religious scholar and get any dua or whatever could be done, but please do keep taking the medicines that we think are important. So we don't try to say this cannot be helped by going for extra prayers or having extra duas as well. So I think this is the important thing. And last question, if you said that when young people as a social worker, they talk about whispers, that could be a sign of a possible very serious mental illness. Patients suffering from schizophrenia, one of the common symptoms is when they start to hear voices of people who are not there, but they're hearing it. So it is very important, because schizophrenia is an illness. The longer you leave it untreated, the poorer is the long-term outcome. So if you leave it untreated for a year, 2 years, 3 years, there is a slow decline in the functioning of that person. So by not going to the doctor or psychiatrist, you're actually affecting the long-term future of that young person. So I think that's why it's important. Please talk, don't suffer in silence, talk to someone, and just don't rely on one type of thinking. Go to your doctor as well. So that would remain my message, really.
Just leading on to obviously the question that someone who's dealing with depression, how do we do this, and how do we sort of interact with these people and help them? And it kind of, because some of the worries is things like suicide and self-harm. Is there anything that we can do to try and prevent sort of self-harm and suicide in men or the general population?
Yeah. So, so just to give you a little bit of idea in terms of figures, so around I think 16 or 17 suicides happen for 100,000 population in UK. That's in men. The suicide is around sort of 3:1 for male versus female. So suicide is more common in men, whereas the self-harm that you mentioned, that is slightly higher in females. So in terms of how do you prevent it, the first thing is what is leading for that person to become suicidal. So the most common underlying mental illness is depression or schizophrenia can also, patients with schizophrenia can also self-harm. Similarly, patients suffering from personality difficulties could self-harm as well. So I think the main thing is that try and get the help for the underlying mental health problems. And this thinking, this concept of not talking about suicide can prevent suicide, so that's wrong. Even as a clinician, we are encouraged to talk about or ask this question to our patients, sometimes directly, whether they have any thoughts of harming themselves, because it doesn't increase the risk of self-harm. So the other thing is, if there is history of self-harm in that patient, or attempted suicides or failed suicides, then that person is going to be a high-risk person. The other factors, if there is comorbid depression, other mental health problems, or substance or alcohol misuse, these people are going to be at a higher risk. If someone is living on their own, or if they're single or divorced, and in terms of age group, mid-40s men would be at a higher risk of suicide. And last message that I would give, if you see someone, or if you heard about someone in elderly who have talked about not wanting to be here, they're actually very high risk of actually successfully doing it. So we should be very careful if we hear from any elderly person talking very negatively about themselves or future. So just, yeah, sorry.
From a community point of view, there are brothers who prefer to speak to another Muslim as opposed to general practice. And even in the go to general practice, there's a huge lot. And we're talking about, certain illnesses that progressive scale get worse rather quickly if they're not treated. At the moment, it's a big weakness. Who can you go and talk to? Even access to the imam is restricted sometimes. But it'd be great if there was a formula or encouragement to some way for brothers to be identified.
Sure.
To be able to move. Because I can tell you now, I deal with a lot of reverts. A lot of reverts come. They come in problems. They even start.
Yes, I can answer
Yeah,
that
exactly.
question, being in community. So
the question was, can you just repeat the question?
so the question is, what sort of services are available apart from GP services, where the waiting time is long as well, for young people or men to access mental health services, isn't it?
Yeah.
So there are actually a lot of services available locally. And the problem is we don't know about those services. I think we need to advertise more. We need to encourage people to get help at the right time from the right service as well. GP is often not the best person to deal with your problems, because GP may be able to give you, small amount of the time, but often mental health needs longer appointments, longer, time with your therapist. So I'll just mention a few organizations locally in Cardiff that you can access. So one of the organization is Mind, M-I-N-D, and they are based on Newport Road as well. And they've got their website. You can contact Mind and they provide a lot of mental health support services, and they have got also counseling services as well. Especially for ethnic minorities, there is care and well-being service called Cause, and it's on Cruise Road. Dr. Hassan from Darul Isra runs that service, and they provide a lot of Dr. Hassan has created this service called Cause. It used to be ISA before, now it's called Cause, and we are actually working with them to provide some counseling services in community through GP services as well. Again, GP services have changed during COVID time. New services have been introduced. Now you can contact your GP surgery, but instead of speaking to a GP directly, you can ask the receptionist to book you an appointment with a mental health nurse, and you can access the mental health nurse directly from your GP surgery rather than speaking to your GP surgery. So as a specialist directly instead of going to a GP. So you can speak to a mental health nurse directly. That's a service available as well. There is other organizations. I think there is a BAME organization, which is also provides some mental health support. There's a website called stepei.org, which is a Cardiff and Vale mental health support services website, which you can get a lot of self-help, and also it signposts you to other services available in the area. So yes, there is a lot of services available, and GP is not the only source of help. So go onto internet, go onto just Google mental health services in your area. You will see a lot of services that will come, and services are actually, some of these services are designed for ethnic minorities. So specific languages, specific groups can be catered for directly through these services.
Yes.
So if I discover somebody who is self-harming and they're also very depressed, very difficult to get motivated, who would I make a reference to?
So you can, as I mentioned, you can speak to if they are imminently, self-harming, or they've done something. Yes, GP would be your protocol as well, or the mental health nurse based in the GP surgery could be accessed as well directly. So you get the right help, because if they need referral to a psychiatrist, that can be done through the GP then, or the mental health nurse.
Or if you're concerned imminently, you don't wait. A&E,
Emergency
if
service.
if it's an emergency, it's imminent. There's a real risk of harm. We agree, mental health service is very difficult. Dr. Amir has been speaking about Cardiff, but we've got viewers who are listening from Newport, from Swansea, from England, all over, and each person has got their own systems in place. So we agree with you, it's very difficult. If you're unsure, speak to your GP. They would at least tell you in their local area what services are available, which comes on to the next point that what Dr. Amir has already spoken about. Before we go on to antidepressants, and it's for both of you or any of you, is and I believe you did touch on it before, that sometimes people just want tablets, because it's the easiest treatment to have. Why could antidepressants not necessarily be the best treatment when it comes to sort of, if it's low level depression or even at the early stages of mental health? And why is it important to maybe go for other forms of treatment rather than tablets?
So depression often can be treated by just lifestyle changes, and medication or tablets is a last resort rather than the first treatment. So often just changing the things around you in your own lifestyle, exercise, diet can have a big impact, a positive impact on the illness or the condition itself. Depression tablets are very useful in certain cases where depression has been going on for a while and you've already tried the health lifestyle advice, it's not worked. You've had counseling therapies, talking therapies that can be very useful before going on to tablets. So often you want to try things which are not harmful in the first place, because tablets carry a lot of problems themselves, and tablets, especially antidepressants, have got problems of side effects. They've got problems of dependence, that you become addicted to them. Then coming off them can be a problem as well. When you're on antidepressants, certain other medications interact with them. You can't take certain medications because of being on antidepressants, and they can cause a lot of other harmful effects as well. So we try, as doctors, we try to prevent any harm. That's our first, step, is to prevent any harm. And often depression can be treated by non-harmful things like exercise, diet. It's a healthy lifestyle is actually good in preventing everything, not only depression, diabetes, blood pressure problems, cancers. It's all well documented, well evidenced that a good lifestyle can prevent a lot of medical and mental health conditions. Dr. Siddiqui would add anything else
No,
to
just
that?
just a couple of points, and if you don't mind, if I could just say about the last point. You mentioned somebody who is self-harming. I think it's very important that if you see someone who is self-harming, you need to get help. And if you don't know the route, then emergency services probably would be the right source. So A&E mentioned as one of the options. So, I mean, don't make a judgment that whether that should wait or could wait. So speak to the right person, or if you can't, then A&E probably is going to be best place.
It's quite essential that we have different options, because the individual person has their own way. But in this particular case we're referring to, which we're not really, but we're too late on that, right? This particular. But it would be great if we could have access to a Islamic front, something could come to that. But the thing was speed, just time, run out of time.
Yeah.
By the time you phone the doctor, they want to make an appointment, they call him in cold, they want to create a case on him, they don't know what to do, they don't know what to sanction him, I mean, or whatever, that they did, and then it just dramatically overrun.
Yeah.
And a bit touching on from Islamic point of view, because he thought he'd done wrong. Islamically, you know?
Yeah, but that comes down to us working with the Muslim community, whether it be the elders of the community, the imams, to know that mental health is not something that's wrong, or that the person who's suffering with mental health illness is in the wrong, or is blameworthy, and that's going to take time for us to do. Also, you're mentioning a very specific case. But it's also important that we get to talk about mental health early on in someone's life as well. That's key as well. And obviously, we've mentioned healthy lifestyle and stuff, but what about counselling? You know, the other non-medical treatments. From my experience, you know, patients want easiest treatment, not the best treatment, because easiest is not. Because obviously the best treatment can obviously be more difficult. Going for counselling, you need to have sessions, you need to talk about what's led you to where you are, and that can be quite painful, or people are not ready to talk about their issues, and they just want a tablet to just make things all easy. Is that the best way to sort of deal with mental health, or should we sort of encourage counselling and to talk about their feelings?
I think when the counselling is the right way forward, we should encourage counselling, and we should try and discourage medication if we believe that in that scenario, counselling is the better option. I know that some people are not psychologically minded, or you said that they are not psychologically or mentally ready. But again, this is a judgment that we should try and leave it up to the counselor to decide whether this person is mentally ready or not. Even me as a psychiatrist, I refer the patient to the therapist and let them make a judgment whether this person is going to be the best person to do therapy or not. Obviously, if patient is very clearly saying, I'm not going to see a therapist, then there's no point referring. But if there is some agreement, then the therapists are quite professional, so they are quite used to dealing with patients who have a lot of reservations about opening up and discussing their personal issues. The other thing is, not every type of therapy involves talking about your past or dealing with personal issues. You know, cognitive behavioral therapy, it's more about here and now, how you're feeling, why your mind is thinking in that way, how can you change your thinking and behavior. So there are a lot of approaches, and generally, again, the psychological therapy department, they are quite capable of supporting these patients.
Sorry. So just coming on towards depression itself, how would a patient know that they needed antidepressants? And obviously you said it's a last resort. that we try to do is in terms of prescribing, and we want to try all other mechanisms. So how would we know that somebody would need antidepressants?
Okay, so again, the patient's role would be to go to the GP, or if GP refer that patient to the psychiatrist, And if the psychiatrist or the GP think medication is the right treatment, then we should take it. Generally, if you're suffering from a clinical depression of a moderate to severe level, then that's where medication are advised. Dr. Ghanghro mentioned that antidepressants, quite often the ones that we prescribe, they're quite clean medicines to be considered in terms of psychiatric medicines available to us. Obviously, we all need to accept that even the simplest medicines like paracetamol would have side effects, or similarly antidepressants could have side effects as well, but not many patients get these side effects, or if the side effects do occur, usually the side effects do settle down if you persist with medication. I could do a little bit of maybe correction, or just to rephrase it. So antidepressants are not addictive. So you do, when you come off them, when the time is right, you should come off them antidepressants gradually. So you should not abruptly stop the antidepressants, but they're not addictive, unlike some other medicines like benzodiazepines, which are highly addictive. So yeah, I mean, when you suffer from moderate to severe depression, or if the depression is recurrent, in which it comes and goes and comes and goes quite frequently, this is where antidepressants along with therapy is needed. NICE guidelines, which is the group of experts who sit and decide what would be the best treatment for each illness, they also recommend that antidepressant along with therapy is the best combination for moderate to severe depression and recurrent depression. So we should give importance to both medication and therapy and lifestyle changes. So we call it psychosocial interventions. So it's not just all up to the therapist or all up to the doctors. It's what you can do to help yourself. So think, how are you living your life, and what can you do to improve the quality of your life? You know, if you're just sitting at home, I'm just giving an example of watching television or playing games and not interacting with people, that's not good. Going out, meeting with people, talking to friends, visiting them, talking to family members, eating a healthy diet, already mentioned, a good sleep pattern, exercise. With exercise, our body releases some chemicals. Sometimes I try to explain to the patients, these are happy hormones. When you do exercise, you get happy hormones, which makes you feel happier. So, and there's a reason that every doctor keeps encouraging a healthy lifestyle.
Also, like little things, little changes like smoking.
Oh, absolutely.
Stopping smoking, reducing alcohol intake.
Yeah.
These can have big impacts.
Absolutely,
Yeah.
absolutely.
I've just had one question in. With the pandemic, has that have you seen an increase in the number of patients who are you're seeing, or as a GP that you're seeing, with everything being locked down, or all the restrictions we've had for 2 years? Are we seeing a sort of larger number of caseloads?
Yes, definitely over last 2 years, especially in young people, we have seen a lot of mental health conditions increased in last 2 years. And because young people, obviously their social interaction reduced, they were not going to schools, they were confined to rooms on computers, screens. I think for a healthy life, a social interaction is a must. Without that social interaction, you will feel isolated. And also then when you're sitting at home, you've got nothing. You mentioned about gaming we've seen causes a lot of anxiety among young people. They keep thinking about it, sitting on bright screens. Even when you're sleeping, your mind is continuously thinking, active around it. So yes, we've seen a significant number of young people coming with mental health issues in the last 2 years. And we have been trying to signpost them to the right services, getting some self-help, early help, so they can deal with it with lifestyle changes rather than going on to the medication. Obviously, there would be some of our patients who would need medication, and that's where we would act and start antidepressant and monitor it. And again, it is not a permanent disease or permanent condition. Once it gets better, we can slowly withdraw the medication, stop it, things get back to normal. So I think it's important to get the help.
Yeah.
And just from a sort of speaking to people in my community, I found that during the lockdown period, you found how much going to the masjid pre-pandemic, how much of a part of human beings' life it was when, you know, people who would come here 5 times a day, suddenly the mosque is locked down, is a place to meet people, see people reach into mosque together, no longer having that social interaction. So definitely we've seen a bigger rise in cases of mental health in the last 18 months, which makes it even more important that we do have these conversations in a non-judgmental way. If someone does approach you, you know, it may not just be about yourself, it may be if someone approaches you, not to minimize what they're saying, because it may have taken them a lot of courage to even come up to you. They trusted you enough to speak to you about their feelings, and that's why it's really important to sort of sit down, talk to them, and guide them and advise them that, you know, that speaking to a doctor may be beneficial for them, and that there's many of us who have felt this way throughout this pandemic.
Yeah, I mean, you rightly mentioned, Kasim, that along with other impacts like, you know, exercise, diet, faith has got an impact as well. We see that people, because faith gives you that social interaction, faith gives you that belief as well. So I think it's important to, you know, get going to the mosque and talking to people will help you to come out of that condition quicker.
Do we have any other questions?
The SSRIs?
SSRIs, yes.
Medication. Why is there such a plethora of them? Why is it such a long road? Like, what happens when you come? Some comes they're depressed or anxiety, or whatever, and you decide that the chemical intervention is going to be maybe a benefit. Then you start on the road of SSRIs. And say, I have these.
So the question is regarding SSRIs.
Sorry, what is SSRI?
Yeah, so SSRIs, I'll get Dr. Adeel Siddiqui to talk about that. SSRIs is a version of antidepressants, and why do we seem to prescribe lots of them when people come in, or all these?
Go through, what are the names? God, there's so many names.
Yeah, the different types.
Okay.
Sure.
Okay.
You go from one to another. That's what you're saying.
Yes. So okay. So yeah, good. Thank you very much. Good question. So we are talking about at a stage now that the diagnosis has been made by a clinician, and they have decided that here is the stage that antidepressants are needed. So most commonly we prescribe the medicines, the group is called SSRIs, which is selective serotonin reuptake inhibitor. And the underlying reason is that we believe that lowering of serotonin in some parts of the brain is leading to the symptoms of depression and anxiety. And if you're through the medication, you're trying to increase the level of serotonin. And so in terms of the choices of SSRIs, there are a number of SSRIs available. We decide on the basis of which would be, first of all, which one is licensed for that illness, because SSRIs are used for depression and anxiety or panic attacks or OCD as well. So we, first of all, decide which SSRI is licensed for that illness, as well as what we believe is the most appropriate in terms of the possible side effects, because Dr. Ghanghro mentioned some medicines interact with some other medicines, including some SSRIs. So we have to carefully select which one we'll go for. And in terms of how we prescribe it, I mean, it's a slow titration. There's no other way around. So there's no fast, quick fix. We have to follow that titration every 4 to 6 weeks, and you go up to the maximum level that you can prescribe, and then you move on to the next one. So that, unfortunately, it's a slow process, as already mentioned before, but that is the right process, because otherwise, if we increase the dose quickly, we are only increasing the risk of side effects rather than helping the patient.
So in OCD, there is a particular individual who started this road, mentioned this road. They have OCD and anxiety.
Yeah.
and they started off with citralopram.
Okay.
And it looks like it's not been effective. So this is 6 weeks. Is this a point? Is this a time that you would say?
Yeah, almost. This is almost the time that the dose can be titrated, as long as the patient is not having side effects. So the dose can be titrated. But again, I would just reiterate that never expect that prescribing medicine is the solution. We still have to focus on psychological interventions as well, including for OCD, because medicines on there's no magic pill, honestly. Medicines do play a role, but counseling also has important role that should be given equal weightage as well.
So the question was just for the live stream, so patient with OCD who may be on an SSRI or a medication, and when would it be appropriate to titrate up?
Yeah.
Are there any other questions, or should we wrap up? Just got everyone for attending and for the questions, whether in person or on the live stream. This was the first Movember event that MDC have done like this, and inshallah the plan would be for more events like this in Dar al Isra and in many other masjids, not only talking about men's health, but any other subject matter or problems that you feel are pertinent in the community, because we are one community and we all want to ensure that we all are well, whether it's mental or psychological. So if anyone does have any other questions that you feel that we haven't answered, please message us. We're on Facebook, Twitter, Instagram, TikTok now as well, or any of the members of our team who come to this masjid, and we'll try to answer those questions or get you some help, get the help that you require. And obviously you can see here, we've got email as well, muslimdoctorscumry@gmail.com, where you can email us and follow us on social media. Everything we do, we hope that even if we can help save one person's life, as it says in our religion, then it's like we've saved the whole of humanity. And that's the way all of us doctors, for Muslim Doctors Cymru, are working. We did this throughout the pandemic, but now we want our work to continue to help our communities going forward. So please, please, please contact us and we will see how we can help you. Jazakallah khair for everybody for watching and for attending, and also to my panelists as well, who I felt have done a really great job answering the questions that were put forward to you, and we look forward to seeing you soon in future events.
Thank you.
That's